can slip, elevator will slip and go on the floor of the mouth. You don't want to do that. Floor of the mouth is very vascular and very vascular, and the bleeding. The roof, the roof of the mouth, the palate. We have an artery comes from foramen, from bones, greater palatine. They call it greater because it's greater palatine. When you have bleeding from greater palatine, it's massive and it's difficult to stop it. You have to put pressure, weight. So think about the complication. I'm not going to scare you, but you think about the complication for that. Fracture buccal bone, lower first molar and upper first molar. Buccal bone usually thick, and we have very big tooth. And buccal bone is very thin and large tooth. Upper first molar has 3 roots, and usually the roots diverge, and the crown is smaller than the root, so it cannot go this way. So when you see in the X-ray, you see the root like this, like tree. You section that tooth. You know how to do sectioning? How we gonna cut it? Section the tooth, resection the roots. Yeah, the upper has 3 roots, so we section the 2 buccal and 1 palate, so it's a T-shape cut. The lower has 2 roots, but when you have 2 roots, sometimes the medial root is larger than the distal root, and you think you're cutting in the middle, and you cut in the medial root, and you put the elevator, get fracture, and so what do? Take X-ray first. You can see and you reflect the gum a little bit. You see the bifurcation. When you see the bifurcation, and go through it, the bifurcation and cut it through. So that's the section. So to avoid the fracture, the buccal plate, usual buccal plate, single plate rarely fracture. Single plate only when we go to the 3rd molar. Single plate will be thinner. Oral-Antral Communication. You know what's Oral-Antral Communication? No. Antrum, the old name of the sinus, maxillary sinus, is Antrum of Highmore. It's a British anatomist. And they put all their names everywhere. Yeah, but it's an Antrum of Highmore. So it's called Oral-Antral Communication. That's the name. But that's Oral-Antral Communication, when the opening from the oral cavity to the nasal. Many times it happens, and the patient doesn't know, and the dentist doesn't know. And the blood clot will heal, and because no problem. So sometimes the tooth non-infected, I don't want you to scrub the preapical area. There's no lesion. Remember, scrubbing, just leave it. Just leave the blood clot. Because sometimes there's a small opening, and you enlarge it with this. So that's one way oral-antral communication can happen. But if you think it's happened, what do? If you think, you suspect it. With the X-ray, you see the root are near the sides. What do? Suture. I want to protect the blood clot. The blood clot will keep. So suture, gel foam, anything to protect the blood clot. Okay? And some people give them anti-allergy because we don't want the patient sneeze. Sometimes we give them nasal drops. And anyway, just limit the irritation to the sinus. Because any irritation to the sinus, there's pressure. Anyway, but even the sinus pressure are negative, mostly negative pressure. There is suction. You've seen the X-ray when the implant is in the sinus. You've seen it? Many X-ray, the small implants will be in the sinus. You've seen these? The dentist, when they do it, the implant is not in the sinus, but with the negative pressure from the sinus, will pull it to the sinus. So there's always negative pressure from the sinus will open. So if there is a small clot, if there is small opening, it will increase. And especially with patients with delay healing, diabetes, smokers, yeah, most of the patients, smokers. That's oral-antral communication. So whenever you think that we have a communication with the sinus, just suture it. Okay, just for this stage. Yeah, to be in safe side. Okay. And I told you can do suturing just for your training, so keep the tissue nearby. Bleeding. Listen, bleeding. We have intraoperatively And we have reactionary, and we have postoperative. What's a reactionary? Remember reactionary bleeding? What the local anesthesia has vasoconstrictor. Remember we give local anesthesia with vasoconstrictor. The tissue will be. We have less bleeding when we work. The effective vasoconstrictor will work for an hour, 2 hours, half an hour, maybe less, maybe more. So around this area, an hour. So after 1 hour, we expect there is bleeding. Okay. Remember when we extract somebody and that guy, and we told him we can wait outside for it? Yeah, I just want to make sure there will be no bleeding. Just wait for a half an hour. Okay. You will get respect from the patient, and you'll sleep better because you know the patient doesn't have bleeding. So that's important. So the bleeding, that's a postoperative. This is reactionary. We can continue later. That's it.